Who is pro all infants should receive oral antiretroviral prophylaxis throughout breastfeeding? Not red yet. People who are red, put your down. Just green.
The red.
Hopefully, Karen, we have our count. Yeah. Okay. And who is con that all infants should not receive oral antiretroviral prophylaxis? Okay. It looks like the greens outnumber the reds a little bit. So we'll have our first speaker list. We'll start with con. Amy.
Okay. Thank you very much to the organizers for inviting me to argue the con side of this debate. So I'm arguing against the motion that all, as it was put, infants, but I've put in HIV-exposed infants, should receive oral antiretroviral prophylaxis for the entire duration of breastfeeding. So I have no conflicts. A few abbreviations to clarify. I will use peri and postnatal HIV transmission, abbreviated as PPT and not MTCT. IPrep to stand for, or be synonymous with, prolonged infant postnatal prophylaxis for the duration of breastfeeding, and MART for maternal lifelong antiretroviral therapy. So my esteemed opponent has written very elegantly about the impossibility of eliminating all HIV transmission during breastfeeding with maternal ART alone. And he's also explained beautifully that suppressed maternal plasma viral load does not equate to a suppressed breast milk viral load. And furthermore, that CD4 cells in breast milk have characteristics that facilitate the establishment of an HIV reservoir in breast milk. And none of this I dispute. And he's also been a strong advocate for HIV-exposed children, that they've been left out of the wider PrEP human rights agenda. And this may very well be so. And I think in this room, we all universally agree that every child does deserve an HIV-free beginning, and that we should be doing everything we can to ensure this. We are also all understandably anxious about the tension between providing the benefits of breastfeeding and the risk that goes with this of ongoing postnatal transmission. But is prolonged infant PrEP the investment that we should be making now to realize an HIV-free start for all children? Or is it just another single modality quick fix? So we'll consider 3 questions to answer this. Is IPrep safe? Will it be more effective than maternal ART alone? And what is the opportunity cost? Or what will we not invest in to invest in IPrep? And then we'll take a quick reality check. From what has been measured, largely laboratory serious adverse events in clinical trials, there do seem to be safe options for prolonged infant prophylaxis. But we actually really don't know for sure. We don't know enough about infant exposure to antiretrovirals in breast milk, and go and watch Catriona's brilliant talk from Croy earlier this year. And we also know even less about the combined exposure to ARVs through breast milk, as well as through direct administration to the infant. And we also should not underestimate that for a substantial proportion of women, there is a traumatic daily struggle to get medication into their otherwise healthy infants. And this can negatively shape the maternal-child relationship for the long term. And if we've learned anything in 2018, it's the need for pregnancy and infant pharmacovigilance systems in low and middle income countries before embarking on mass drug exposures. So on safety on infant PrEP, we've got a lot still to learn, in fact. Will IPrep, in addition to maternal universal antiretroviral therapy, further reduce postnatal transmission? By meta-analysis with maternal ART, postnatal transmission at 6 months of age is around 1.1%. So let's compare this to infant PrEP. We know from HPT and 046 that infant nevirapine given to 6 months of age to breastfeeding infants can also reduce transmission to around 1.1% in comparison to placebo at about 2.4%. From ANRS 12174, which I'm sure you'll hear a lot more about from my opponents, both infant lopinavir/ritonavir and lamivudine reduce postnatal transmission at 12 months to around 1.4 to 1.5%. But to note, even giving a potent antiretroviral like lopinavir/ritonavir directly to infants, transmission was still not 0. And who wants to be giving lopinavir/ritonavir to infants every day? PROMISE has been the only study that has directly compared maternal ART postpartum to infant prophylaxis. and up until 18 months of age. At postnatal transmission at 24 months of age, in both of these groups was less than 1%, with maternal ART being at least as effective as infant nevirapine. So what about that unreachable breast milk viral reservoir that we're supposed to be concerned about? Surely if this was a substantial contributor to postnatal transmissions, then infant nevirapine would have been more effective in the postpartum phase of the PROMISE study. The major unanswered question, though, is what if we give infant PrEP in addition to maternal ART? Will we have an additive effect and reduce transmissions below what maternal ART alone can do? And this we really don't know. The only evidence we maybe have to go on here is from a small subset of HPT and 046, where a small group of mothers were on maternal ART at the time that their infants were randomized postnatally either to receive prolonged infant nevirapine or placebo. And there was really no difference in this group in transmissions, whether they received infant nevirapine or placebo in this group of moms on maternal ART. So are you ready to expose 1.4 million infants annually to extended infant prophylaxis on that evidence base alone? I'm certainly not. So a big no to question 2. So what is the opportunity cost going to be? What will we not invest in to invest in infant PrEP? I'm certainly in full agreement that we need to be doing something about postnatal transmissions, shown here in blue, that are starting in some countries to outweigh peripartum transmissions in red. So why wouldn't we give infant PrEP? It doesn't look too harmful, and surely we might prevent a few more kids from acquiring HIV infection. In 2017, only 4 of the 23 focus countries managed to reach more than 95% coverage of pregnant women living with HIV with antiretroviral medicines. Countries to the left of the blue line in this slide that reached coverage of lower than 95% account for more than 80% of all remaining peri- and postnatal transmissions. So are we really going to consider adding prolonged infant PrEP in these countries where there is still so much work to do and so many peri- and postnatal transmissions that can be prevented by focusing on adequately scaling up universal maternal ART? Adding prolonged infant PrEP in countries like Nigeria, that still accounts for 25% of all transmissions, is going to add a complex distraction to optimizing an intervention that we know works. And maternal ART doesn't only work to prevent peri- and postpartum transmissions, but it keeps the moms alive, well, and able to give their families the nurturing environment that they need. So even where women are receiving antiretroviral therapy, there are many challenges to keeping postpartum mothers engaged in care. We know by meta-analysis that at 12 months, postpartum retention is about 76%. We know from Malawi that even those that are retained in care, only 30% achieve adequate adherence 2 years post-initiation in pregnancy. And we know from Cape Town that also in women retained in care, only 70% manage to sustain suppression to 12 months postpartum. Common factors have emerged from studies on what is associated with disengagement from care, and particularly from qualitative work, the fear of disclosure, social discrimination, major logistical barriers, finances, transportation, time commitments. Postpartum life is complex for women living with HIV. We need to accept this, engage with it, and work harder to overcome these barriers that are important for both women and families living with HIV. And women living with HIV really deserve more than just another single modality quick fix. So let's look at infants. To retain infants in care, or is retaining infants in care going to be any better than retaining women in care? And from this meta-analysis, only 66% of HIV-exposed infants were retained at 3 months of age. And I think low early infant diagnosis rates also attest to this challenge that HIV-exposed infants have really been notoriously difficult to maintain and follow up. To draw from another example of prolonged postnatal prophylaxis, the use of isoniazid preventive therapy for tuberculosis-exposed infants, programs have really struggled to reach 20% completion rates for infant IPT. Why is iPrep going to be any different to this? So again, I say, infants at risk of HIV infection deserve more than a quick fix. Let's invest the $20-odd million that it would cost just for the drugs for IPrep into supporting, understanding and supporting women living with HIV during the complex antenatal and postpartum periods, and supporting the health systems that need to implement these interventions. So what is the opportunity cost? I think diverting from optimizing maternal ART is too high a cost to pay by adding infant prophylaxis. But let's take a quick reality check. So Nonhlanhla is the mother of 22-month-old Apilile. She lives in the rural town of Adherence in South Africa, where she's returned to work on the grape harvest season to earn income to send back to her mom in the Eastern Cape, who's looking after her 2 older children. Nonhlanhla had previously worked in Adherence the previous summer, had been well connected to care, had never missed a month of picking up her antiretroviral therapy, was well suppressed, and her daughter Apilile was HIV uninfected at 18 months of age and still breastfeeding. For economic reasons, Nonhlanhla migrated to the town of Citrusdal, about 300 kilometers away, to work on the winter citrus harvest. While there, she was on a farm 20 kilometers outside of town, difficult to reconnect to the clinic, and didn't continue her ART while she was there. She returned to Adherence the following summer to work on the grape harvest again, immediately reconnected to the clinic that she knew. She was still breastfeeding Apilile. Apilile was tested for HIV, and Apilile was HIV infected. Would prolonged postnatal prophylaxis have prevented Apilile's HIV infection? No, it wouldn't have. So in reality, prolonged infant prophylaxis fails. We can do much better than a quick fix. We need to work harder at scaling up maternal ART, where there are still many gains to be made. Work harder how to understand women living with HIV through the antenatal and postpartum periods. And I love Shafiq's suggestion of differentiated models of postpartum care and potentially targeted interventions now really to reach elimination. And we need to loudly advocate for the structural, systemic changes that families living with HIV need to be empowered to fight this disease. So let's all just keep calm, keep our heads, and do more than just another quick fix. Should all HIV-exposed infants receive oral antiretroviral prophylaxis for the entire duration of breastfeeding? No. Just to acknowledge and appreciate a few friends and colleagues that have given some input into these thoughts. Thank you.